Okay, tamam. Thank you, Dr. Baligh and Dr. Samir, for this kind introduction. I'll gladly share my slides now, but I don't know, is it clear for everyone or?
Are you using it in a portrait mode? Try to tilt your, if you're using an iPad.
Okay, I'm using my phone actually, but I'll try to
okay.
tilt.
Yeah, tilt it so it will become in the landscape mode.
Okay.
Perfect.
طيب تمام. طيب أول شيء كمان بس معلش. Because it's not moving great. Okay. So مساء الخير جميعا. I know that we have tonight, so I'll try to squeeze my presentation. I'll take like 45 minutes. So as Dr. Baligh said in the introduction, is it really a cerebral palsy? So I'll be presenting this a very important topic that we as neurologists sometimes face a situation where we being consulted to assess or evaluate a CP patient and then turn to be, or ultimately we will discover that he is not really a cerebral palsy patient and he has been misdiagnosed. So what is cerebral palsy? So strictly, the term cerebral
I think we lost you, Sarah. I think we lost you.
Brain with infancy spanning from birth up to 1 or even to 2 years of age. So here, as I went through the definition, we can say that for 2 years of age with another course. The surveillance there are as a start with the risk factor that result in like a brain insult. We can say that also we have the prenatal or infantile HIE, hypoxic ischemic encephalopathy, insult, intracranial bleeding, kernicterus, family history of cerebral palsy, infection or head injury, cerebral vascular accident. So we have some of the red flags in the history, examination and neuroimaging we should consider while taking the history or do the examination for the patient. So the red flags are here summarized as in the history, we should not find like any risk factor for cerebral palsy, such as the prematurity, low birth weight, multiple birth, hypoglycemia, jaundice, kernicterus, as I said before, intracranial hemorrhage, infection, stroke, head injury, positive family history for cerebral palsy, fluctuation in the motor symptoms. This goes opposite to what we said in the criteria. It should be like static motor dysfunction. Paroxysmal symptoms in relation to time of day, diet, fasting, or activity, progressive neurological symptoms, regression of milestones. These components we should keep in mind and consider while taking the history. And for the examination, whenever we find like dysmorphic features, isolated motor dysfunction, such as isolated ataxia, isolated hypotonia with no dystonia or spasticity, peripheral nervous system abnormalities like absent reflex sensory signs, eye movements abnormalities, oculomotor apraxia, paroxysmal saccadic eye head movement, and optic atrophy, retinopathy. In the neuroimaging or in the brain MRI, we should keep in mind that the red flags for in the brain MRI should be prompt to consideration of another diagnosis, which is the normal neuroimaging, non-specific abnormalities such as isolated globus pallidus involvement, and imaging might demonstrate a specific lesion rather than it's not going with the prenatal brain injury. So we have those types for the cerebral palsy. Depends on the predominancy of the pattern of the motor pattern. Like if the patient is having predominantly spasticity or dyskinesia or ataxia. So on this schedule, I'll talk about, or you can see here the types of the cerebral palsy, some examples for each. Well, like disorder with prominent spasticity, we can see that we have the hereditary spastic paraplegia, originase deficiency, biotinidase deficiency, cardiac syndrome. And for the disorders with prominent dyskinesia, we can see that we have the dopa responsive dystonia, sympapturin reductase deficiency, glutaric aciduria, and we have the glucose transporter deficiency type 1 for the disorders, and the list here goes on. For the disorders with a prominent ataxia, we can see that we have here the ataxia telangiectasia, Bilzis, Merzbacher disease, Joper syndrome, and the list goes on as well, Niemann-Pick. So I'll start with the diagnosis of with a prominent spasticity. I have here a small cute clinical scenario. I'd like some of the neuro resident or general pediatric resident to interact with me. So if you have a baby with a baby boy, let's say, patient who presented or he was picked up at 2 years of age with a motor impairment and rapid psychomotor regression, we have sent for the genetic testing. It showed It showed the ARSA gene. So what do you think here? And this is here attached his brain MRI.
You can post the answers in the chat box. Okay, time's up. Give them the answer, Sarah.
So يا جماعة الخير لازم صحصح عشان نخلص بدري عشان الماتش الكبير يلا. So this is MLD, metachromatic leukodystrophy. Okay, so it is an autosomal recessive lysosomal storage disorder, primarily caused by the mutation of the, as I said, ARSA gene. which encodes the aryl sulfatase enzyme. The lack of enzymatic activity leads to accumulation of the toxic substrates in tissues such as gallbladder, pancreas, kidneys, and most importantly, the myelin. The myelin, which is يعني it is the form, it is the substance that forms the new cell. This would cause the progressive dysfunction of central and peripheral nervous system, and pathogenic variant in ARSA gene classified as severe or mild based on the residual enzyme activity. We have three main clinical phenotypes, depends on the onset and the characteristics, so late infantile, juvenile, and adult. So for the late infantile, start at day 1 of life up to 2 years and 5 months. The characteristics or the presentation would be mainly early motor impairment, rapid psychomotor regression, and premature death. For the juvenile presentation, it would be from 2 years and 6 months up to 16 years. And the characteristic or the clinical presentation would be the combination of motor and cognitive defects. For the adult gestation, it would be above 16 years. And the patient at that time would present with cognitive decline, behavioral, and psychiatric disturbances. Okay. So we have another scenario here. We have a 30-year-old man present for evaluation for gradually progressive lower extremity spasticity, which has worsened slowly over the past 5 years. On examination, he has spasticity of the lower extremities with no evidence of lower motor neuron findings and no other neurological abnormalities. He states that he has a family history. His father had the same condition, and his younger brother now is starting to have difficulty walking. So workup has been done for this patient, including MRI, cervicothoracic spine, and it was unremarkable. They have sent for B12 copper levels normal, and he has normal CSF as well, negative virology panel. So what do you think that the diagnosis here? Anyone? ما أدري أنا صوتي واضح يا جماعة ولا؟
Yeah. لا, it's very clear. Okay, خلاص. So give the answer.
Okay, so this is hereditary spastic paraplegia. So it is a wide and heterogeneous group of genetically determined neurodegenerative disorders that share common clinical features of lower limb spasticity and muscle weakness. There is considerable phenotypic and genetic heterogeneity. Almost more than 80 genes described so far associated with the HSP. According to the clinical phenotype, mode of inheritance, and the affected gene, the HSP syndromes are classified into complicated type and the uncomplicated type and the complicated type. For the uncomplicated type, the patient would present with purely progressive lower extremity spastic weakness, typically occurred in the 3rd decade of life, as the example we mentioned in the previous slides, and inherited, and it is inherited in autosomal dominant fashion. For the complicated type, where spastic paraplegia is associated with neurological and non-neurological signs such as peripheral neuropathy, cognitive impairment, extrapyramidal manifestations, ataxia, brain imaging, and imaging abnormalities. They usually present in early to mid childhood and are usually inherited in autosomal recessive pattern. So most of HSP patient, not all, have a slowly progressive weakness. Some of them would may be non-progressive, as observed in the infantile onset HSP. Cases with de novo mutation in SPG3 related spastic paraplegia or DDHD2 related spastic paraplegia. Those patients are commonly misdiagnosed as having spastic diaplegic or paraplegic cerebral palsy. brain and spinal MRI may appear normal or show specific findings suggestive of an HSV syndrome, such as brain atrophy, thin corpus callosum, spinal cord atrophy, and lipid peak, as observed in the D2 mutation. So for the other, now I jumped, we will not have a case here. For the other condition or syndrome or disorder that we have, spastic disorder that can mimic cerebral palsy, which is the call for a one-related spastic cerebral palsy. So it is, as I said, it's a collagen vascular disorder, which may cause an antenatal or perinatal cerebrovascular insult, resulting in a neonatal stroke syndrome that manifests as hemiplegia or quadriplegia. Screening for the mutation in this gene should be undertaken in all neonates and infants with a stroke syndrome in the absence of any antenatal injury and prematurity, or with MRI features that are not characteristics or for PVL, cerebral infarction, and the distribution of the anterior or middle cerebral artery. So I'll move on to the next condition that might cause like spastic or can mimic spastic cerebral palsy, which is the biotinidase deficiency. It is an autosomal recessive inherited form of multiple carboxylase deficiency. The clinical presentation for such a patient would be hypotonia, seizure, ataxia, developmental delay, metabolic acidosis, optic atrophy, in addition to dermatological abnormalities such as skin rashes and alopecia. Patient with a delayed onset by biotinidase deficiency may develop motor limb weakness and spastic paresis, attributed to spinal cord involvement, commonly misdiagnosed as cerebral palsy. So for such a patient, the work and the workup we will proceed with, and the treatment, of course, we will start with the MRI, which will show a signal abnormalities in the white matter of the spinal cord. Diagnosis of biotinidase deficiency is confirmed by demonstration of deficient enzyme on a dried blood spot. It's included in the newborn screening and in many countries. So early treatment with biotin result in a resolution of the cutaneous and neurological manifestation, whereas the audiological or ophthalmological manifestation sometimes would like be resistant, or it will take time to be resolved. So moving on to the next condition or next disorder that we have, the aragonase deficiency. It's an autosomal recessive urea cycle defect. Patient will present mainly with the between 1 and 3 years of age, with the developmental delay, motor and cognitive progression, slowly progressive spastic paresis, acquired microcephaly, and failure to thrive. Ataxia and seizure may also develop. So identification of a mutation on the gene here, we can pick it up in the aragonase deficiency, ARG1 gene. So early diagnosis of such a condition and early sustained treatment with low aragonase diet and nitro scavenger drugs may ameliorate some of the impairments associated with the disorder. So now we are done with the disorders that mimics spastic cerebral palsy. Moving on to the disorder that mimics dyskinetic cerebral palsy. So I'll start with this brief short scenario. We have a 9-month-old child presented with encephalopathic crisis, preceded by an URTI symptoms. His MRI is shown here below. Anyone would like to tell us what he think about the diagnosis?
Okay, let's see some answers in the chat box, please.
Sorry.
So a summary with this MRI. Summary, Sarah.
طيب اوكي. سوري بس لانه تكفل عندي دقيقة معلش. So as we can see here that for this patient, this is a T2 axial cut MRI for a patient that his image is demonstrating now a fronto-parieto-temporal subdural hematoma with mass effect, and he has like diffuse brain atrophy and a widening sylvian fissure. Unfortunately, I cannot point it out. I don't have like a pointer here. And we can see that there's some sort of ventriculomegaly. So anyone answered, or shall I move on?
I think the chat box has maybe some issues. You can write in the Q&A section if anyone wants to contribute.
Okay, I'll move on. Yani, it seems like.
Sure, move on.
Type. So this is glutaric aciduria type 1. It is a rare autosomal recessive metabolic disorder caused by a alteration in the GCDH gene. Most untreated affected children present with an encephalopathic crisis followed by a febrile illness in the first 6 years of life. These crises will cause striatal injury and consequent dystonic movement disorder. MRI finding is in glutaric aciduria type 1 is presence of widening of sylvian fissure and basal ganglia abnormalities. Diagnosis can be made by urine organic acid analysis and genetic studies that will show the GCDH gene. So moving on to the next condition, we have the GCH1 related DOPA responsive dystonia. It is it's commonly misdiagnosed with as cerebral palsy. It is inherited in autosomal dominant inherited and autosomal dominant metabolic disorder of the dopamine synthetic pathway. Typically, they presented at childhood with gait disorder due to foot dystonia, diurnal fluctuation, and improvement with rest or sleep. Patient would have a normal intellectual and cognitive function. So the confirmation of this diagnosis by the genetic testing would be by picking the GCH1 gene. Levodopa usually at low doses is the mainstay therapy is the mainstay of therapy with complete resolution of symptoms. So if we interfere like early and we catch it up early, the patient might have like a normal childhood. So cipipaptrin reductase deficiency, it is an autosomal recessive disorder caused by mutation in the cipipaptrin reductase gene. The triad for this condition is oculogyric crisis, paroxysmal stiffening, and hypotonia. Those are the hallmark for this disease. This feature has typical diurnal fluctuation with sleep patterns. In some patients, the clinical manifestations are non-specific, and they have been misdiagnosed with cerebral palsy, hypotonic cerebral palsy, hypotonic or dystonic cerebral palsy. So neuroimaging generally is normal in cipipaptrin reductase deficiency. Analysis of CSF, neurotransmitter, and SPR gene confirms the diagnosis. It's a treatable neurometabolic disorder, and early treatment with a combination of L-DOPA and 5-hydroxy tryptophan results in a good neurological outcome. So the next condition we have here is the ADCY5 related dyskinesia. It's a significant genetic cause of early onset non-progressive hyperkinetic movement disorder. Typically, the onset for it is 6 months of age in a patient known to have hypotonia or motor delay. The movement disorder would be in form of dystonia, chorea, choreoathetosis, and it's typically would occur like in episodic and sleep. It would be sleep related. So this dyskinesia may exacerbate upon awakening, falling asleep, or during intercurrent illness for a few minutes up to days. The exacerbation of dyskinesia in relation to sleep should prompt consideration of underlying ADCY5 mutation. They may have normal cognitive function or mild intellectual disability. Otherwise, they would have like brain MRI. A patient with the ADCY5 related dyskinesia are frequently misdiagnosed as hypotonic dyskinetic cerebral palsy. So moving on to the next condition we have here for the dyskinetic mimickers for dyskinetic cerebral palsy, we have the cerebral folate deficiency. Typically presents, those patients would present at the age of 4 to 6 months as an infantile form, mainly in form of behavioral change and a refractory epilepsy. Whereas after 1 year of age, the presentation would be like spastic ataxic syndromes that can mimic cerebral palsy and progressing to dystonia and schizophrenic syndrome in adolescence. So workup for such condition would be diagnosis would be like based on the low CSF level of 5-methyl tetrahydrofolate and normal plasma folate levels, confirmed by FOLR1 gene analysis. Folic acid therapy results in significant improvement for such a patient. So moving on to the next condition, we have the Lesch-Nyhan syndrome. It is a rare X-linked recessive disorder of purine metabolism caused by mutation of at the age of 3 to up to 6 months. Occur in the positive and a disorder of the brain aneurysm caused by a mutation in the SLC2A1 gene, which encodes the glucose transporter protein type 1 that is required for glucose to cross the blood-brain barrier. So we have two phenotypes here, the classic phenotype and the non-classic phenotype. For the classic phenotype, early onset in intractable epilepsy, and the patient would have like delayed development, and they would have like acquired microcephaly, movement disorders such as ataxia, spasticity, and dystonia. For the non-classic type, patient would have intermittent ataxia, dystonia, exercise-induced dyskinesia, and alternating hemiplegia. Okay, diagnosis and treatment for such a case. We said that ataxia is and involuntary movement often fluctuate in severity and getting worse while with fasting or with exercise. So brain MRI would be sometimes normal or may show mild cerebral atrophy and subtle white matter abnormalities. The diagnosis is confirmed by the genetic testing, and we would find this mutation in the SLC2A1 gene. The treatment basically is on the depends on the ketogenic diet or modified Atkins diet, which is highly effective in controlling the seizure and improving the gait disturbances. So now, lastly, what I would talk about the disorder that, or the CB mimickers that would, like CB mimickers with prominent ataxia. So first, I would start with the ataxia telangiectasia. It is multisystem autosomal recessive inherited disorder caused by a mutation in the ATM gene. Patient would present with progressive ataxia, oculomotor apraxia, oculocutaneous telangiectasia. Diagnosis and workup for such a patient: a brain MRI would show like progressive cerebral atrophy, and blood test would be would show high level of the fetoprotein and absent immunoglobulin A, and analysis of the ATM gene confirms the diagnosis. Okay, so I put the image here. Anyone is interested to say what is the abnormality here in this MRI?
You can use the Q&A box. Or the chat box, if either one is working. Okay.
So I'll move on. So this
Yes,
is
please.
a typical brain MRI of Pfilzes-Merzbacher disease. It is an X-linked inherited disorder of myelination due to mutation of PLP1 gene, encoding the PRP2 lipid protein. Classic PMD presents during early infancy with head bobbing, nystagmus, psychomotor retardation, tremor, ataxia, progressive spasticity, dystonia, and athetosis might occur on the long run. So PMD can be misdiagnosed as cerebral palsy in early stages because the spasticity is slow and progressive, and brain MRI finding may not appreciate abnormalities during the first year of life. Last, I'll end my presentation with the Duper syndrome, which is a genetically heterogeneous group of disorder with an autosomal recessive or X-linked inheritance. It's characterized by hypoplasia of the cerebral vermis and classified in the group of ciliopathies. So as it will affect the cerebral vermis, as a result of it, the patient would present with ataxia, mainly the truncal ataxia. So clinically, ataxia is the predominant neurological sign. So, and we can see here that the pathognomonic feature for Duper syndrome and MRI is the molar tooth. So as a take-home message, please, MBS is very important in picking up cases, treatable cases, okay? And it can be treated cases can be treated effectively, such as vitamin deficiency, MSUD, and now it is the time to revise the diagnosis of cerebral palsy. Not every patient would present to our clinic or to the emergency department with spasticity, dyskinesia, any abnormal movement, any movement disorder would be labeled as cerebral palsy. We have a lot of mimickers for cerebral palsy, and it's not fair for the patient to be labeled as cerebral palsy where he has any a different disorder or disease. So this is my reference. I had a look on this great article, which is entitled Metabolic and Genetic Disorders Mimicking Cerebral Palsy, which was very beneficial in making this presentation. Do you have any question, guys?
Thank you, Dr. Sarah, for a very interesting talk.
يعطيك العافية دكتور بليغ على كمان السوبرفيجن. بس الظاهر الناس مشغولين بالمباراة.
لا I'm sure we'll get few questions.
It's okay, it's fine.
Okay, so I don't think there's any questions. I would like to end the session here and hand over the mic back to our colleagues, Samir. And just to remind you that we have next week, we have the General Assembly for Pediatric Neurology Society meeting, same time, 8 o'clock. The links and agenda will be sent to the members. Thank you so much.
يعطيكم العافية جميعا. شكرا لكم.
Thank you, Mr. Badir.
Okay. Thank you.
Thank you for everyone. موفقين إن شاء الله في المباراة.
سامح أنت موجود؟
معاك يا فندم.
خلاص الجمهور لسه موجود جالس 500 نفر جالس.
نسيت حضراتكم. طيب
لا خلاص